everyone for attending today's webinar. We would like to thank Dr. Jennifer Jones for presenting today's webinar. This is one of many webinars we have scheduled for 2020, so I hope that you'll be able to attend the rest of those as well. My name is Layla Moomin, and I am the Community Engagement Coordinator for the Canadian Cancer Survivor Network. Today's webinar is called Canadian Cancer Rehabilitation, CanRehab Team, Improving the Systematic Identification, Management, and Treatment of the Adverse Effects of Cancer. We are pleased to welcome our presenter, Dr. Jennifer Jones. She is the Butterfield Drew Chair in Cancer Survivorship Research and the Director of the Cancer Rehabilitation and Survivorship Program at the Princess Margaret Cancer Centre. In addition, she is a senior scientist at the Princess Margaret Research Institute and an associate professor in the Department of Psychiatry and the Dalai Lama School of Public Health at the University of Toronto. The diagnosis and treatment of cancer can result in chronic side effects that can interfere with a person's ability to work, engage socially, and do daily activities. There is an urgent need for research that can help to inform care for cancer survivors, including the early identification of physical side effects and the development of effective cancer rehabilitation treatments that can be supported and maintained by our healthcare system. The CanRehab team brings together a group of patients, researchers, and clinicians at 4 Canadian centres and includes 3 concurrent projects focused on improving access to effective, appropriate, and timely cancer rehabilitation. In this presentation, Dr. Jones will provide a background on cancer rehabilitation, introduce the CanRehab team projects, and provide an overview of the team structure, including a call for interest to the Patient Advisory Committee. At the end of the presentation, our speaker will answer your questions. However, at any time during the webinar, please feel free to type questions into the window at the bottom right of your screen. For those of you who have not attended an earlier webinar, the Canadian Cancer Survivor Network is an organization working with cancer patients and survivors to learn about health system complexities, connect with others to plan action, and act to promote best care and healthier survivorship. If you would like to learn more about CCSN, please visit our website at survivornet.ca. This webinar is being recorded and it will be available tomorrow on YouTube. In addition, slides will be available on SlideShare. Links to both will be sent to the email you provided. Now I will turn things over to our presenter. Welcome.
Great, thank you so much for the introduction, and it's my pleasure to be here today. I will turn off my webcam for the presentation just so that I spare you the internet bandwidth, I guess, and it doesn't freeze for you. So, but I'll come back on at the end, okay? So I'm going to turn off my webcam now and share my slides. All right, great. So as you heard in the introduction, my plan is to present a little bit of an overview on cancer rehab, just to sort of set the scene, and then talk to you about an exciting new team that I'm a part of here in Canada, and talk to you about what our team's planning on doing, which is called the Canadian Cancer Rehabilitation Team. So to start with some background, I'm sure most of you are very familiar with this, but as you know, we have nearly 1 in 2 Canadians are expected to be diagnosed with cancer in our lifetime. And there are over 1.5 million people now living with a personal history of cancer in Canada. And looking forward, given that we have an aging population, it's projected that there will be a doubling of the number of individuals living with a personal history of cancer by 2025. So in Canada, that means we'll see at that point 3 million people who are living with a personal history of cancer. The good news is, though, that mortality rates have dropped significantly, and even though we see an increased incidence, more people are surviving. And there's a couple of reasons for this. First, we've done a good job of tobacco control, getting people to quit smoking or not start smoking. We have better ability to detect disease much earlier, in which case it's much easier to treat. And there's lots of developments in terms of treatments. So better treatments to including, all new types of chemotherapies, different targeted radiotherapies, and then immunotherapies, those types of things. So that has made huge inroads in terms of being able to really treat and combat cancer. So now what we're seeing is that the 5-year age standardized survival rate for cancers, all cancers combined, is about 2/3. when you measure it from the date of diagnosis. But when you look at those people who have survived the first year after their cancer diagnosis, this increases to 81%, which is great. And this graph here is one that I just recently came across, which I really like. Usually I like to show Canadian stats, but I like this graph, and I'll explain it a bit to you. So this is based on United States data, but it's not dissimilar to what we would see here in Canada. And basically what it's showing is 5-year survival rates, comparing what they were in between 1970 to 77, which is the pink dot, compared to where we are in 2007 to 2013. So the sort of bluey purple dot. So as you can see, this bar here, the top one at the top that says all cancers, was for all cancers combined, and shows that back in the 70s, the 5-year survival rate was at about half, and by the time we got to the early 2000s, 2007 to 2013, it was up to 67%. And for many cancers, we've seen huge progress. So, for example, prostate going from 67 to 98% survival, thyroid, even some of the leukemias where we went from 30% to 60%, and we're even seeing progress in some of the cancers where there's very high mortality rates. So these are all wonderful trends, and really I think just sort of strengthens our argument that we need to start looking at issues post-treatment as well as during treatment. So when I talk about cancer survivorship, there's lots of different terms that are sort of thrown around. The first one is what is a cancer survivor? Who is a cancer survivor? And there's many different definitions. I think the one that's most widely agreed upon is that a person is considered a cancer survivor from the point of diagnosis through the remainder of their lives. And in very broad definitions can also include family members as well. But when we talk about cancer survivorship as a part of care in the cancer trajectory, often what we're talking about is this phase post-treatment, when people have done their diagnosis and staging, had their treatment, and then are in sort of that follow-up phase where they're in a disease-free remission, getting surveillance to monitor for disease recurrence. In some cases, this includes people who are living with sort of managed chronic or intermittent disease, so disease that's coming back, gets treated, and then they sort of go back into remission. And then if they have a recurrence or secondary primary, they go sort of back to the beginning of this trajectory. So that's often what we think about when we're talking about cancer survivorship as a sort of treatment phase. So I like to, I like to sort of spend some time thinking about why it's important for us to think about cancer survivorship and cancer rehabilitation. And, first of all, we often don't think about the long-term and persistent side effects of cancer and what it ends up costing people. And a lot of people have started to think about cancer as more of a chronic disease, but unlike other chronic diseases like diabetes or arthritis, where disability and impairments are often caused by the disease process themselves, in cancer, very often what you'll see is a person sort of going about their lives, functioning very well, getting diagnosed with cancer, undergoing sort of a combination of different treatments, some of these very aggressive, and then sort of coming out at the end of this sort of cancer system, dealing with many side effects of their treatment, and often dealing with disability. And there are a number of different challenges that are cancer survivors face. So you might hear different terms like acute, persistent, or late treatment effects, and I'll just define each of these so you know what I'm talking about. So as you probably know, almost all different types of cancer treatment, whether it be surgery, systemic therapies, radiotherapy, can result in side effects that can impair a person's well-being, whether it be their physical or psychosocial functioning, and also can impact on their overall quality of life. And in most cases, a lot of times people will get these side effects while they're actually receiving the treatment, and this is called acute side effects. But for some people, even when their treatment ends, the side effects, those acute side effects that they develop during treatment, seem to last for many months after treatment ends, even though they're not receiving treatment anymore. So a great example of that might be fatigue. The large majority of people will develop fatigue during treatment, and that's to be expected. And for most people, once treatment ends, that fatigue over the next couple months will slowly go away and they'll start sort of feeling back to normal again. But in some cases, about a quarter to a third of people, that fatigue persists. And we're not really exactly sure why, but it persists for years, even decades after treatment, and can seriously impair a person's ability to function and their quality of life. So in that case, that would then be called a persistent treatment effect, something that developed during the acute treatment time and persisted. But there's also something called late treatment effects, where people may develop a brand new side effect months or even years after their treatment ends, just sort of out of the blue. So those are called late treatment effects, and something that we also need to monitor for and be aware of. I think it's really important to understand that the survivorship experience is highly individual, and it's very difficult to predict who will develop persistent and late treatment effects and the course of those effects. So it's hard to sort of say, oh, how long, when will you start feeling better, or who's going to develop what different treatment effects. In terms of physical side effects, anybody who's had cancer, obviously we are always concerned about local and distant recurrence of their disease, and we monitor for that. So people will come back, every 3 months, 6 months, 12 months for their surveillance. And we're also looking for second primary cancers as well. But as I said, treatment can affect almost all of our different body systems and result in these persistent and late effects. And those can include things like cardiac or respiratory dysfunction. Sometimes people have cognitive impairments, which they sometimes term chemo brain, or problems with memory. Pain is very common, fatigue, neuropathy, which is sort of the tingling in your fingers and toes, functional limitations, sleep disturbance like insomnia, sexual dysfunction, and infertility. So these are some of the more common physical side effects that people can develop either as acute, persistent, or late side effects. And often these symptoms coexist in what we call symptom clusters. So somebody may have fatigue as well as sleep problems and cognitive impairment that all sort of happen together. And we also know that these side effects are often worsened by other comorbidities that people may have, and exacerbated by age-related processes, and also can be impacted by your sort of lifestyle behaviors, so whether you're physically active and those types of things. This is an older study, but I think really is an interesting one. This is a study that was published comparing people who had so cancer. The gray line bar are people that have a history of cancer, and the blue bar is people that have no history of cancer. So they matched people who had a history of cancer and people who did not have a history of cancer, and looked at sort of their health and their activities of daily living and functional limitations. And as you can see, the people that had a cancer history had much poorer ratings. So more of them, about a third compared to about 10% of people with a cancer history, said that they had fair or poor health. About 10% had more than one limitation of their activities of daily living, more functional limitations. And we see, and this is something we see in the literature quite a lot, is that these types of difficulties with function and activities of daily living can also impact a person's ability to work. In terms of psychosocial well-being, patients and their families also face a number of significant psychosocial and economic consequences as a result of a cancer diagnosis. In cancer survivors, probably the most common is a fear of cancer recurrence, which was very common, but people also describe having uncertainty, anger, anxiety. There's emotional vulnerability. Certainly issues related to sexual dysfunction and altered body image are often common. People also describe lots of changes in sort of social outcomes, changes in their relationships, the way they communicate with people or are involved in their community. And there's lots of practical concerns that people have to deal with in terms of getting back to work, employment and insurance discrimination, health and life insurance implications. And this kind of really impacts people's financial health and their ability to work. Unfortunately, these conditions are often underdiagnosed. People don't report them. They're undertreated as a result. And this is unfortunate because there are effective psychosocial interventions for people. I'll just finish by, maybe some of you have seen this, but there was a great study that was done across Canada by the Canadian Partnership Against Cancer, and they surveyed over 12,000 people who were post-treatment about their experiences, and looked at needs in terms of physical, emotional, and practical concerns. And not surprisingly, to me at least, 8 in 10 respondents had physical challenges after their treatment had ended, and fatigue and changes in sexual function were the biggest concerns. 7 in 10 reported having emotional challenges, and 4 in 10 reported having practical challenges after their treatment ended. And unfortunately, most people didn't seek help for these problems. So, you know, and a lot of the reasons why this was that people said, oh, I thought it was normal, or somebody told me I was normal, or I didn't think there was anything that could be done about it, or I didn't want to ask, I was embarrassed. And that's unfortunate because we do have services that can help people. So that, I hope, provides a little bit of background and context to what I want to present to you today now, which is introducing you to the Canadian Cancer Rehabilitation, or CanRehab Team, which is a team of researchers, clinicians, and hopefully survivors after today across Canada. And our goal is to improve the systematic identification, management, and treatment of adverse effects of cancer. And this is a team that was recently funded through the Canadian Institute of Health Research, as well as the Canadian Cancer Society. And we're funded for 5 years. And it involves 4 different centers across Canada. So I'm here in Toronto at Princess Margaret. One of our other leads is Dr. Kristen Campbell, who's in Vancouver and working with BC Cancer. Jonathan Greenland is a radiation oncologist who works in St. John's, Newfoundland. And then Anthony Riemann, who's in St. John's, New Brunswick, who is an oncologist hematologist. We also have Dr. David Langelaire, who's a new investigator, and he's a physiatrist, so he's an expert in rehabilitation medicine. So these are the 5 PIs that make up our team. But we have a larger group, as I said, of clinicians and researchers that make up the CanRehab team across Canada. And I believe actually our team is over 50 people, which is fantastic. It's a huge team and lots of energy and excitement to move this forward. So what I want to do today is provide you with a bit of an overview of what we've been funded to do, and then hopefully see if we can get some of you involved. So I'll start by providing an overview of our team goals and the research projects, and then I'll talk about the team structure. So the goal of our CanRehab team really is to bring together a large group of researchers, clinicians, and cancer survivors. As I said, this is happening at 4 cancer centers across Canada. And the goal is to conduct 3 different projects that are linked, and the focus of these projects are on improving the systematic identification of the adverse effects of cancer and its treatments, increasing access to cancer rehabilitation using e-health solutions, and extending reach to cancer rehab, and by including a growing population of cancer survivors, including those living with incurable or metastatic cancer. And I'll go into detail of each of these. But I think what's important, and really what, you know, the reason why we wanted to do this is that, you know, we strongly believe as a team that for a healthcare system to achieve optimal patient outcomes, It needs to aim to control and focus obviously on the disease and the cancer, but as well on the consequences of its treatment in order to improve the functioning of its for individuals and for a growing number of cancer survivors. Now, as I mentioned, there's 4 different centers across Canada that are taking part in the CanRehab Team. And we have 3 studies. Our projects are focusing on 4 different types of cancers. So this does get a little complicated. 4 sites, 4 cancers, 3 projects. So just keep that in mind. So the 4 cancers that we're focusing on are breast, colorectal, head and neck, and lymphoma cancers. And I'll go into detail of each of these projects, but the first project is really focused on trying to identify cancer rehab needs by developing and evaluating an online system to screen patients for cancer-related impairments and to link them to cancer rehab services. The second project is testing an 8-week online cancer rehabilitation program and looking at how we can implement that program across Canada. And the third project is to develop and assess the feasibility of a rehab program for patients that have a stable metastatic cancer, so advanced cancer. So as I said, project 1, the focus is really on identification and driving people to resources that may help them. So the first project is called the Development and Implementation of an Electronic Prospective Surveillance Model for Cancer Rehabilitation. So what is a prospective surveillance model? Basically, a prospective surveillance model is a routine assessment of survivors' needs, and for our focus, it's on survivors' functioning during treatment and post-diagnosis and continuing into treatment survivorship. So basically, it's monitoring patients' needs over time and asking patients, how they're doing, basically. And the reason why we want to develop a prospective surveillance model for cancer rehabilitation is that, as I said, there's an increasing number of cancer survivors who can expect a relatively normal life expectancy. And so failure to treat these cancer-related side effects, given whether they be persistent or late side effects, may adversely affect a person's well-being or function for many decades. Treatment-related side effects and impairments are very common, as I've outlined in the background, and often go underreported or unrecognized. Many treatment-related impairments can actually be prevented or treated through early identification and by providing early education, self-management, and comprehensive rehabilitation. So we have interventions that can help. But finally, very few survivors receive such care. So even though there are services available, most people are not getting access to these services. And, despite the fact that we said that we want to have a prospective surveillance model where we're trying to identify cancer-related impairments and rehabilitation needs of our cancer patients, we know that there's a lot of challenges to implementing these, and this has probably been the reason why they haven't been implemented up until now. First of all, it's not really clear when we need to intervene and with who, and if a person scores a 5 out of 10 on fatigue or a 3 out of 10 on fatigue, when do we need to intervene and provide services? So there's not a lot of data to help inform these types of systems. So some people have said we need to refer all patients to cancer rehabilitation specialists to screen for possible impairments. But unfortunately, that's given our healthcare system and funding, it's not cost effective. It's not possible with our current workforce limitations, but also it's not patient centric. If somebody's not dealing with any side effects or feeling great, there's no need for them to have an appointment with a cancer rehabilitation specialist and waste their time, really. So we need to figure out when we need to intervene and with who, and having everybody referred to specialists is probably not the solution. The other idea is implementing systematic screening within oncology clinics. So some people might experience this when they go into their oncology clinics. They're asked to fill out questionnaires about their symptoms. That helps the oncologists understand sort of the needs of the patients. But we know that oncology clinicians are often challenged with really busy clinics, and we know here at Princess Margaret that in some cases they don't get a chance to look at those scores. But not just that, they don't always know where to refer patients to or what services are available in a person's community given a certain problem. So they're not always expert in the different rehabilitation services. That's not their expertise. So in order to address some of these barriers, obviously a prospective surveillance model needs to include clear pathways to appropriate resources and interventions, and should really be personalized to tailor responses and dose based on the level of risk and need, and avoid sort of a one-size-fits-all where everybody gets the same. And so some people have proposed that we could use technology. It's potentially a cost-effective but also patient-centered solution for the implementation of a prospective surveillance model for cancer rehab. And in this case, what people have proposed is allowing for remote monitoring, so patients can remotely report on how they're doing in terms of different impairments or side effects. And there can be automated and personalized linked treatment responses that could be built into this type of system. But unfortunately, these types of systems have yet to be developed or implemented, which leads us to our first project, as I said, which was the development of an electronic prospective surveillance model for cancer rehab. And so what we plan on doing is developing such a system, an electronic remote monitoring system that would screen for rehabilitation needs and have a risk stratified automated response built into the system to deliver support and connect patients to the level of rehabilitation services that they require. And we're calling this system, as you can see on this screen here, the REACH system. And these are sort of mock-ups of what it might look like, but obviously we're just in the design phase right now, and hopefully we've had some patient involvement up till now with some different workshops that we've run, but we are hoping to get more people involved to helping us. So it would be where a patient would just get a prompt to check in, get asked some really simple, quick questions about how they're feeling in terms of certain physical symptoms, and then based on the responses, they'll have different programs or services provided to them if needed. So the aims of our project are, for the first year and a half of the project, are really just to create this system, which we're in the middle of doing now. And then following that, we're going to actually implement the system into our 4 centers across in our 4 CanRehab centers and test it out. And that will be sort of a pilot where we're testing it out, learning the system, getting feedback from patients, seeing that the system's working properly, refining the different algorithms that are built behind the system. And then finally, we'll do a full implementation at the end of the project, where we really explore how to maintain this system, how to ensure that it remains sustainable and maintained. And at the same time, we'll also develop a nice cohort of people who are going through the system who want to share their data for research purposes that we can collect research data on, but also patients will have the opportunity to be invited to different research studies that they might be eligible for if they're interested. So that's the goal of Project 1. And as I said, really the focus of this is to help identify issues early on and get people connected with services in their area. The second project is a Pragmatic hybrid type 1 effectiveness implementation trial. So I'll explain this to you in a minute. But the exciting thing is that it's testing a virtual cancer rehabilitation program. And the goal of this is really to improve access to cancer rehabilitation services. So there's evidence right now that when we look at the literature on cancer rehabilitation, it's very strong, showing that there's good impact and good evidence to support the need for cancer rehabilitation, and that cancer rehabilitation can help people get back to work, improve their function, and improve their quality of life. But most of this research to date has come largely from trials that provide cancer rehabilitation face-to-face in a clinical setting. Unfortunately, we know that a lot of cancer survivors face significant barriers, whether it's that they live far away, it's expensive to come into the centers, they have poor health, they're fatigued, they have childcare issues, they have work barriers, those types of things that prevent them from accessing cancer rehabilitation services that are delivered in person. So one thing that has been suggested is that we could develop maybe some of our cancer rehabilitation interventions using technology, so people can access these things from home. And this approach actually has been fairly well developed in other chronic diseases such as heart disease and diabetes, but in cancer, it hasn't, comprehensive cancer rehabilitation hasn't really been developed or tested using e-health interventions. So e-health technology, I think, presents really exciting opportunities to increase access to cancer rehabilitation in a virtual setting. And there have been some studies showing that with cancer patients and cancer survivors, that e-health technology can increase physical activity and reduce specific psychosocial and physical symptoms in cancer survivors. So project 2 is testing the effectiveness of a virtual cancer rehabilitation program for patients who have identified cancer-related impairments, and also look at the factors that affect implementation so that we can learn how to implement this type of program across Canada. And so this is going to be a study that will happen across our 4 centers as well. And it is a randomized controlled trial. So patients will be randomized who take part in this study would be randomized to either receive the intervention called Care at Home or get put on a waitlist control. So the Care at Home intervention is an 8-week program where patients would get registered into the system. They get weekly e-modules that provide interactive education and promote self-management skills. They'll be provided with an individualized progressive exercise prescription supported with a mobile application that gives them, they can look at videos on and track their own personalized exercise prescription through this app. We also give participants a Fitbit to help track their activity and sleep and help with keeping their motivation up. And then they'll get weekly calls with their kinesiologist and exercise professional to have check-ins, help adjust any issues that they have with their exercise, and progress their exercise, and help them with motivation and getting motivated to implement the different behaviors that we're trying to get people to do. In the waitlist control, they'll during the course of the study, they'll receive usual care. And then following the last assessment for the study, they will be offered the Care at Home group program. Sorry. And the second aim of the project, as I said, is we really want to focus on implementation. So really developing sort of a toolkit so that if other centers are interested in implementing this type of program, we would have sort of what they need to do, what are the resources required, what is the cost, those types of things. The third project is a phase 2 randomized controlled trial of a group-based cancer rehabilitation program for people with metastatic cancer. And the focus of this is really on extending reach of cancer rehabilitation to beyond those with just who have finished treatment, to include the growing number of people who have advanced cancer and are living long time with metastatic solid tumor cancer. So there's been huge advances in the treatments of cancer, as I said at the beginning, and this has not only led to increased survival, but also and sort of cure of cancer, but also prolonged survival and a growing population of people who are living for years and even decades with metastatic solid tumor cancer, so advanced cancer, that is sort of managed with treatments that they will have intermittently. The issue is that these treatments can be quite grueling, especially since they're taking them for long periods of time, and can lead to loss of physical function, deconditioning, fatigue, pain, and high levels of psychosocial distress. And improving this loss of functional independence and high symptom burden is described by people who have advanced cancer, metastatic cancer, as one of their highest medical priorities. So typically cancer rehabilitation interventions haven't really focused on this population, but they certainly can address common impairments and reduce the rate of functional decline in patients that have advanced cancer. But these programs are underdeveloped and underutilized. And so there's been recently, given the growing number of people who are living long-term with advanced cancer, urgent calls for the development and evaluation of proactive multidimensional interventions to address the needs of this growing population of survivors who may be continuing to live for years with their impairments and undergoing treatments. So that's what Project 3 is. It's testing the feasibility of an in-person group cancer rehabilitation program focused on maximizing potential for independent function and also promoting quality of life for people who are living with incurable, locally advanced or metastatic solid tumor cancers. And the goal really is to test the feasibility, so ensuring that it's feasible and safe to deliver this program. So it's going to be a group-based program. It's delivered over 8 weeks. It's very similar to the virtual one in terms of the format. There's 1 hour self-management education that the group will get, and then the group also does 1 hour of exercise together in the gyms. But people also get, oh, I don't know why that's happening. People also get, I don't know what happened to my slides here. Sorry. Something happened. Oh, there. So people also get their individualized exercise prescriptions too, and are expected to do some exercise back at home in between their weekly visits. And the control group will receive standard best cancer care, which will be provided by their oncologist and healthcare professionals and their palliative care team if they have access to that. So those are our 3 projects, and I'm happy to answer more questions about those, but I just want to finish by talking a little bit about the team structure for CanRehab. So it is a bit of a complex team structure, but as I mentioned, it is a very large team, and we are we're hoping to do all these 3 projects, and I think it's quite ambitious. And so it's important that we have some really good structure to help us along the way. So we have a steering committee, which is made up of our study PIs, who are the 5 PIs that I listed at the beginning of my presentation. Dr. Lanchelere is also leading a training program for trainees so that we can develop capacity in cancer rehabilitation across Canada. Jackie Manthorn is also our patient rep from CCSN. And Sarah Neal Stramsko is our implementation science lead. So really trying to focus on how we can actually implement all these things that we're learning into standard of care for patients. We have an operations committee. We have an external advisory committee that includes experts from around the world. And then we have project teams. So each team has its own, each project has its own team that will be leading that. But what I want to talk to you today is about our Cancer Survivor Advisory Committee, which is probably the most important committee, I think, and will help to advise on all of our projects and sort of our overall goals. So I'll give you a little bit of an overview just to finish off on what that's going to look like. So the Cancer Survivor Advisory Committee is going to play a key advisory role as an overarching committee in order to ensure that the cancer survivor's perspective remains at the forefront of everything that we do and influences the direction of the research and also the implementation activities and helping us to understand what's going to work and what's not going to work. And the mandate for this committee is to help build a sustainable, accessible, and equitable cancer care system, and to improve the care provided to cancer survivors across Canada. And in order to do that, it's essential that patients are integrated into the research process in a meaningful and substantive manner. The roles and responsibility. So the committee will advise the CanRehab team from their perspective as cancer survivors and also caregivers or community members throughout the research and implementation process. So this will include providing feedback and ideas on the CanRehab project methods and implementation, helping maybe working with some of the project teams and research design teams to focus on making sure that we're focusing on issues important to cancer survivors, An example would be in Project 1, ensuring like the design of the electronic prospective surveillance model is something that will work for cancer survivors, helping us to identify issues, gaps in services, support, and programs that might be helpful for what we're trying to do. We ask that our committee members commit to attending 3 meetings per year as an active member and being an active member in those committee meetings, collaborating with others in a respectful manner to enhance the care model, drawing upon their own personal experiences constructively and providing specific perspectives that contribute to diversity of perspectives of our committee members, and finally, promoting the inclusion of all voices in decision making. What I'd like to do is sort of make a call out to all of you on the webinar today to consider joining us. We really would like to have an active patient, caregiver, survivor advisory committee helping us to improve the delivery of cancer rehabilitation in Canada. It's important that we have this committee. So if you're interested in getting involved, please contact our team coordinator, Charmaine Silva. Her email is here. We can answer any questions that you might have. We have a terms of reference document that we are in the process of finalizing that we can share with you if you're interested. And our goal is to have our committee sort of in place and have our first meeting in the new year. So I'm going to finish here. If you have any questions, feel free to contact me directly. As I said, Charmaine is a great person to contact if you're interested in the committee, or you can contact me as well. I have a bit of time here now to answer any questions that you might have right now. And I'll turn on my webinar or my video camera again.
Awesome. Thank you so much for that presentation. We have quite a few questions in the chat, so we'll start with this one.
Okay.
Based on the numbers presented at the beginning of the presentation, such as 81% overall survival rates, 1.5 million living with a history of a cancer diagnosis, how does this account for people with multiple cancer diagnoses? And how does this mesh with the statistic often mentioned by the Canadian Cancer Society of 1 in 2 Canadians expect to get cancer?
Well, I would say that that's accounted in those statistics. So it's true that some people will have multiple secondary cancers, multiple cancer diagnoses. I'd have to get back to you on whether they count those. I believe that they would count each diagnosis as a separate diagnosis. So yeah, it's a little bit of a tough question for me to answer, but if you'd like, I can try to connect you with the Canadian Cancer Society to get specifics on that if you'd like.
Thank you. Next question. Why is it that sexual dysfunction is not talked about when so many women get a cancer diagnosis and have to live with the new normal that has no sex or little to no sex?
Yeah, I would agree that this is something that's really highly underreported. Part of the issue is that healthcare providers aren't asking about it, and survivors are sometimes embarrassed to talk about it. There are services in some places. There's definitely a need for more services. I'll just encourage you to know that in our prospective surveillance model, one of the things we will be screening for is sexual dysfunction. So that is definitely on our radar of increasing access to the services for patients that are experiencing sexual dysfunction, both females and males.
This next question is a bit more about the logistics of the project and involvement. So somebody asked, would I be able to participate in the committee or in the project if I don't live in the area of where the centers are or that location?
Yeah, that's a great question. Sorry, I should have clarified that. That's fine. That's fine. Ideally, you have one of the diagnoses. So remember, it's breast, colorectal, head and neck, and lymphoma. Although I think, even though we're focusing on those 4 disease sites, the goal is that, if we can successfully implement our electronic surveillance model, or if we show that our care at home program is effective and can be implemented, that it would be rolled out to all cancers. So I don't see any reason why we would even need to limit our advisory committee to those cancers. So if you're interested, please reach out and we can talk to you more about that.
And again, about involvement in the advisory committees. So how would caregiver participation work?
So yes, we are including caregivers on the advisory committee. They bring their own perspective. These projects are primarily focused on the patient or the cancer survivor themselves in terms of screening for their symptoms, and if the interventions are delivered just to the patient as opposed to the caregiver. But we know that the caregiver plays a huge role in terms of helping to support cancer survivors in managing their symptoms and reporting their symptoms. And so I think it would be really important to have that viewpoint on our advisory committee. And I think ultimately our goal will be to try to expand some of what we're developing to also address caregivers' needs as well.
Next question, has there been any research on long-term issues caused by the cancer care system experiences versus the cancer or the treatments?
Not that I'm aware of.
Quick answer.
Good question. Interesting question. Very interesting question. Yeah.
Okay, another question for the advisory committee, is the expectation to attend meetings in person or virtually?
Yes, sorry. Well, they will be primarily virtual. And certainly right now with COVID, they will be virtual. I think, there has been some discussion of whether we can maybe do over the team is funded for 5 years. So over the course of that 5 years, maybe having a kickoff meeting and maybe depending on the funding that we have, having some in-person face-to-face meetings would be great. Right now, that's definitely off the table. So we're proceeding with virtual at this time point. But I would say the majority of meetings would be virtual, whether or not COVID is in play or not.
Next question. You mentioned extending reach for metastatic solid tumor cancer. What about sarcoma soft tissue tumor cancer?
Yeah, so that's sarcoma is not one of the cancers that we're including right now in our projects, but that, as I said, we're learning from those 4 disease sites only because we had to limit it. We couldn't include all disease sites in our projects, but what we learned from these 4 projects certainly can be extended to all disease sites. Care at home, there's no reason why it can't be delivered to all different people with all different cancers. Same with the Care Advanced Cancer program. That doesn't have to be limited. For the purpose of the study, it will be limited to 4 disease sites, but what we learn from it and how we move forward, we're actually piloting it here in Princess Margaret already, and we are not limiting it to any disease site. So yeah, I mean, the goal is to roll out to all disease sites as we learn and we go through these projects. And because the big focus is on implementation, I think that's that is one of the things that we're going to focus on when we're talking about implementation and how to roll out to all the different disease sites. Developing those toolkits, understanding needs of other disease sites as we move along.
Thanks. Next question. I am very perplexed that the emotional aspect of the fear of cancer recurrence is not discussed with our oncologists, as this is very debilitating for cancer patients. Why is self-compassion not proposed as something to help patients by physicians and only traditional medications are provided?
Yeah, I would agree. It's the most common psychosocial issue that cancer survivors will report is fear of cancer recurrence. It's not surprising. I think everybody has some form of fear of cancer recurrence. Certainly, as you get closer to your follow-up appointments, your anxiety probably increases, and waiting to get the results from your scans and things like that can be really difficult for people. But in some cases, some people become extremely debilitated from that anxiety, and it's not uncommon. The encouraging thing is there's some really great leading researchers and clinicians in Canada that are developing in-person and online programs for cancer rehabilitation, or for fear of cancer recurrence, and also for caregivers who also deal with that too. We often forget the caregiver, but they also deal with fear of cancer recurrence as well. And I'm involved in a couple of those projects, and they're really, really exciting and important. And I would agree with you that it's not discussed in the clinical appointments when you're coming for your follow-up visit. And part of that is that, again, the oncologists sometimes don't feel comfortable talking about it, aren't aware of what the resources are to send people to. There's an underfunding for psychosocial services. So those are some of the barriers, I think. But I agree with you, it's a really, really important issue. And I am encouraged with some of the things that are being developed here in Canada. And if you want to follow up with me about that, I'm happy to connect you with some of those people who are doing that important work.
Great, thank you. Next question, if we participate in the committee, does that disqualify us from participating in the projects?
Oh, that's a great question. I think it probably would, but we could talk about that. We haven't made any decisions about that. Yeah, so why don't you reach out to us, and we can make that decision as a group. And then if it means that you can't and you want to take part in the studies, then you don't have to be part of the committee. So we can figure that out together.
Great, thank you. So I think that's all the questions that I see here so far. If anyone else has any last minute questions that they want to ask, you can get those in now. Oh, another one popped up. So how soon will the virtual care rehabilitation trial start?
Okay, so I probably didn't include the exact date. So right now we are working on project 1, which is the development of our prospective surveillance model. Our funding started in the beginning of the year, so we're lucky in that a lot of the work that we've had to do this year is really just the development of the platform. And so COVID hasn't really interrupted that at all, because it's a lot of sort of behind the scenes sort of work that we're doing right now. The trial 2, which is the virtual rehab program, and trial 3, which is the program for advanced cancer, they're not going to start for another year or so. So again, we'll probably wait until, certainly for project 3, where it's a group-based program, we have to wait till we can actually get together as a group. And right now, we can't run anything group with COVID. Hopefully in a year from now, we'll be in a different situation. We are doing a pilot study of the advanced cancer one right now, so that we're just refining the intervention and ensuring that it's in good shape to roll out for our phase 2 study. We've just published a paper, and if any of you are interested, I can share it, a pilot study on the care at home virtual program. So we're just making our final changes to that before we go into our phase 3 study. But again, both of those will probably not start until year 2 or year 3 of our funding. So 2021, 2021, 2022. And also, you know, that gives us lots of time to get input from our Cancer Survivor Advisory Committee. You know, I think right now our focus has been on Project 1. And so, you know, that's really what we're trying to get up so that we can start implementing and piloting it in year 2 and 2.5.
Great, thank you. I think that's the last question. So we're almost at 2 o'clock, so we'll stop there for now. Just to conclude everything for today, thank you so much, everyone, for attending today's webinar. And thank you, everyone, for your really thoughtful questions that you provided at the end there. Again, we would like to thank Dr. Jones for taking the time to present this webinar and for informing us all about this really important project that we hope you'll be able to get involved with. As I mentioned earlier, we have many more webinars scheduled for the rest of 2020, and we hope to see you at some of those as well. Next week, we actually have 2 webinars going on. We have a webinar on Wednesday, October 28th at 12 p.m. Eastern Time, and this will be the 4th webinar in our 8-part empowerment series called CCSN's Remarkable Cancer Survivor's Guide to a Healing Diet with Dr. Rob Rutledge and our guest presenter, dietitian Erin Roman. So this has been a really awesome series that we've been able to launch so far, just helping people, especially during COVID when we're not able to have those in-person support group meetings. Doing this virtually over Zoom has provided some of that community feel. So if you haven't been able to attend so far, we really hope that you'll be able to join us for the last 5 webinars in the series. And then on Thursday, we're back for another webinar at 1 p.m. called Listening and Learning with Impact, exploring ways to partner with those who are seldom heard, featuring Ali's Maybe and Dr. Ambreen Sayani. So we'll be sending out email blasts today with some registration information so that you'll be able to sign up and hopefully attend those webinars as well. Thank you again, everyone, so much for attending, and have a great day.
Thanks, everybody. I really appreciate it.